historically, a lot of the work that happens in community mental health is grant funded, which is great. But there are certain things that grant funding is great for, and other things that it's not designed for. I don't know what grant would have given us the $10 million it took to put in like world leading technology.
You're listening to Decoding Healthcare Innovation with Carrie Nixon and Rebecca Gwilt, a podcast for novel and disruptive business leaders seeking to transform how we receive and experience healthcare. Okay, welcome back, everyone. I am so glad you decided to join me for another installment of Decoding Healthcare Innovation. I am excited to introduce you to Anna Lindow, who is the CEO and co-founder of Brave Health. And Brave Health is a virtual clinic on a mission to expand access to high quality and affordable healthcare for mental health and addiction. I'm sure you know why she's on here. These are sort of my favorite topics to talk about. I'm going to give a little bit of background, a little bit more background on Anna before I move on to ask her lots of interesting questions. Prior to Brave Health, Anna was able to 4x a venture-backed tech education company called General Assembly in just 3 years. So she's got the stuff. And she's got a track record of consulting and advising mission-driven startups like her own. I'm super excited to chat with her about building healthcare innovation businesses, how her company's addressing the unique challenge of making mental health care more accessible, in particular to the country's Medicaid population. Anna, welcome.
Thank you so much for having me. Happy to be here.
Yes, so happy to have you join me. So I know that you have a personal connection to the mission of Brave Health. Not all of us turn our life experiences into our livelihoods. So I'm curious about the journey that brought you to this point.
Yeah, well, it wasn't linear, I'll tell you that.
Journeys never are.
Very winding. So, I think I first got interested or sort of had on my radar what behavioral health care was when I was a teenager. My mom got sick and died when I was in high school. And I sort of knew something was wrong, and with myself, and I wanted to talk to someone, and I wanted to see a psychiatrist. And my parents, who were and are fantastic parents, and my had health insurance, sort of struggled, I think, a little bit with the concept, as if it was admitting something that was wrong or could have been shameful. And this is, now over 20 years ago. And the thing that's amazing is a lot has changed between then and now. And so at that time, I kind of put just like a little bookmark in the back of my mind somewhere about what getting care meant to me, because I ended up getting care, and it was great care, and it changed my life. And I don't know where I'd be if I hadn't gotten it, but it wouldn't be here. I can tell you that much. So I remained sort of aware of the impact that mental health care as an adolescent had for me. And through my adulthood, my young adulthood and into my adulthood. And, I did a bunch of other stuff, and worked in the media and was working in startups. And I ended up landing at this company, General Assembly, which you mentioned, Rebecca. And when I learned that running operations in a mission-driven startup was a job you could have, I was like, okay, so someone could have told me this like 10 years ago. I could have skipped the internship at UBS.
Yeah.
Great if it works for you, but it wasn't for me. And it took me kind of a little while to land where I felt I really was meant to be, and kind of at that point said, this is what I'm going to do.
Was it the pace of it? Was it the autonomy? What was it that drew you to it? I mean, there's a special type of person that ends up in these kinds of jobs.
Special is a word for it. I think that you have to, there's definitely a type of, you have to like a certain type of intensity, and sort of relentlessness. I like to be on a mission that works for me. I like moving fast. So definitely the pace. I liked the team feeling. The idea of being sort of like co-conspirators for a shared goal that was and remain, it's just the best feeling. And I loved the idea of doing things that hadn't been done before. Sort of being able to look at a system and say, it's this way, and we don't think that a system that's this way does everything that it's supposed to be doing, and nobody's stopping us from doing it differently. And that was really cool. And so we got to serve thousands and thousands of students across the world, and we got to see people change their lives and start new careers. And we also got to see a lot of people blocked in their career journeys with, by other things going on in their lives, including but not limited to sometimes serious mental health challenges. And so that kind of got me thinking again. And I always knew I was considering, someday I might want to do something in the space. But then GA was getting ready to sell, and I had been in New York for a really long time and wanted to try moving somewhere else. And the
You had climbed that
moment,
mountain. You were
yeah,
ready.
yes, yeah, and I'd been hanging out you know, on the mountain for a while. It was
Yeah.
like, let's go try a different mountain. So, my uh, dear friend and the CEO and co-founder of General Assembly said, "Didn't you always want to do something in behavioral health? Like, well, now's your moment. You're gonna go do something else. You're leaving GA. You're kind of starting fresh. You're maybe moving. You could you have no tie. I mean, I had no ties to anything. I could just pick up and go and do whatever I wanted, which was so freeing and also terrifying." And he said, "Well, what if you turned your operations skills on doing what you have this real passion for?" And right now, the opioid epidemic is not getting better, increasingly getting public attention as it should. And
Right. And
he
this was
knew
back
this.
in 2016,
2016, yeah,
2017. Yeah.
2016, yeah,
Yeah.
exactly. His dad and brother are
Other
physicians, and
insanity also happening at that time, I recall.
yeah, yes, very a lot of change going on in our world for sure. And he said my dad and brother are physicians, and they have a community health organization that serves primarily Medicaid beneficiaries, and they mostly treat opioid use disorder. It's out in Portland, Oregon, and you should go check it out. And I think you'd be interested in this. And that trip to Portland kind of kicked off where we're at today. So saw what they were doing, fell in love with the concept of doing something in community health. Started working on what is now Brave in Florida. Ended up going back to school. I did a program in the med school in addiction at University of Florida, and then a master's in psychology. And now we very quickly moved from being focused on opioid use disorder to being broad-based mental health, with just serving all of Medicaid, and really all insurance, but with a focus on Medicaid, and serving sort of the full spectrum of behavioral health conditions. And that's where we are today.
Yeah, I was going to ask you about this in particular because I represent, hundreds of, healthcare innovation companies and interact with these founders often. And of course, it's all in the healthcare space. But many of them are non-clinical founders, and I wanted to ask you about what motivated you to go and get the master's in psychology and the graduate certificate in addiction recovery. Do you find that that's important? Do you find that you use that often as the sort of leader of Brave?
I do. I do. Um, I mean, I'm not a clinician, but I have a master's in the field now, and I learned a lot. It was a really useful program. And I think the biggest thing it did for me was give me a broader understanding of the research in the field, which is not just the research that I directly interacted with during the program, but also just the ability to look at and synthesize research, which is helpful because when you're doing things that are, you know, haven't been done before, but are we're ultimately operating in an evidence-based care, you know, model and universe. I think it's just being able to see what's out there and what has been done and internalize and understand it is really powerful. Um, and yeah, I was fortunate that that worked out for me.
Yeah, it's interesting you bring up sort of evidence-based models. That always makes me think of my sort of college research assistant days, and data, right? And we just had Dr. Tom Insel on the show, who talked about how we need to be looking at mental health data a lot more to sort of guide our interventions, to be able to determine whether what we are doing is successful, et cetera. and he talked about the mental health crisis that we're going through now, and really the promise of digital tools to address that. And then a couple of weeks before that, we talked to Vic Bakru at Circolo Health, which I know you're familiar with, and he was talking about the importance of bringing digital health tools to or digital health innovations to serve Medicaid enrollees, to tackle some of the big sort of health equity challenges we're facing. And I feel like your work is sort of at the intersection of these two topics. Yes?
Yes, and I am very proud to know both of them, Tom and Vic, and have learned an enormous amount from both of them. So yes, that's a compliment that you just paid me. Thank you.
Well, you're very welcome. I mean, what you're doing is something that I think is novel, and you're also doing it in the midst of pretty serious mental health crisis. I don't know how it sort of ranks among the crises we've had as a country, but I've done a lot of reading in the last couple of years, and combination of COVID and increasing isolation and the aging population. We're in the middle of a really an inflection point here. So you started in 2017, around the time that this was sort of in its nascency. Not that we've ever been great as a country in providing access to mental health services, but what is that like to be building in an environment where there's not just a bunch of sort of venture capitalists that want to invest in mental health companies, but that the problem has never been more salient?
It's interesting. There's kind of a tension because there are really not a lot of venture capital companies that want to invest in Medicaid behavioral health startups.
That's right. That's right.
So
That's right.
it's an interesting thing where it's sort of there's this enormous amount of money and attention on the broad category, but 1 in 4 people have Medicaid and get almost nothing, or have not benefited from the influx of investment.
Yeah, I mean,
Um,
you've chosen to focus on Medicaid in an environment where most mental health startups are still operating sort of direct to consumer cash pay. Um, it may be a easy question to answer, but I'm interested in it. Why Medicaid? Why focus on the Medicaid population?
yeah, and to be clear, all of this work is needed. There is nobody, I don't believe there is any part of the United States where there is truly enough access to behavioral health services, right? This is an overarching, broad, nationwide issue. Um, but I do think that the barriers are more, the most significant and have the most nuance for the Medicaid population. And so I think, I do really understand why it's not often a place people start, because I think you get things that are not always synonymous with the feeling of being able to innovate. High regulatory barriers, long regulatory timelines. There are states where it took us 18 months to get a Medicaid number.
Wow. Wow.
Really, and multiple notary trips.
Yeah.
And frankly, a lot of the work that we're doing now would have been and was harder. We were a fully virtual organization before COVID, but now there is broader adoption, but there's also broader just acceptance of the value of telebehavioral health and less of a resistance to this isn't as good, or it can't work as well, or why are we doing this, and this is a second rate, like if you can't see someone in person then maybe we'll resort to telehealth. That's definitely changed, which is
Do you think
great.
that's changed among both providers and those seeking therapy?
Yes, I do, yeah. At health plans, we
That's
see
great.
so much more willingness on
Yeah.
the part of other providers we work with to make referrals or to suggest telehealth to a member. And some of these things are real barriers. It's really recently that smartphone ownership for Medicaid beneficiaries caught up to the national average among adults. That was not until like 2019. And so what's happening now wouldn't have been possible. And thank God that happened before COVID.
Right. I was going to say 2019. That's exactly what it should have happened for
Yes,
sure.
just under the wire for people to actually have the device
Yeah.
to be able to access telehealth.
Yeah. So tell me, this sort of blends into what my next question was going to be. We're hearing a lot these days about tequity, right? Making sure that we use technology to increase equity. And, for a person that starts saying, like, how can we move the needle for a Medicaid population? What made you think a digital, like a virtual clinic, is the answer to this?
So 20% of our patients are in rural areas. And when I say rural, I mean rural, like fewer than 2,500 residents. Um, so, in that sense, it's kind of the only option. Like we sort of have to use as a constraint. There isn't a reality in which people are going to drive 2 hours once a week to get care, even if they have a car, which a lot of our patients don't. So
Yeah.
even
Shout out to the powers that be. We need broadband everywhere.
well, and so
Thank
that's
God
what I
for
was
them.
going to say. That's what I was going to say. Thank you so
Yeah.
much for going there. And of course, 80% of our patients do not live in those areas. But even then, realistically, there's, first of all, in-person care should exist. Hybrid is important. There needs to be in-person care. We don't want to get rid of it. Like it serves a very important purpose. But if we realistically are looking at the facts and saying, can we build enough exam rooms fast enough? Like one of the health plans we work with, they're a managed behavioral health organization and they get referrals from the physical health plan. They told me that in 2019, in 2018, they got 8,000 referrals of people who needed the behavioral health case management support that they offer. And in 2019, they got 24,000.
Holy moly.
Right. Before COVID. And so if you think about that, are we going to wake up and have triple the office space of it? Like there just is no way. And so I am an enormous believer in the power of virtual care for a number of reasons. It does not replace care that happens in an office setting, but I think we have to just accept this as a reality. Like there is no other logistical option that could work. And so we're very fortunate in behavioral health that actually most of the services we offer can be effectively delivered. I feel for, providers of other types of services that don't lend themselves as well. But behavioral health is also something that, you're going to have pretty frequent encounters. Getting somewhere once a year for a dermatological screen is easier than weekly care, right? So how many other providers do you see weekly? It's not that common.
Yeah.
So there's some
Hopefully, yeah.
nuances.
Hopefully very few.
OBGYNs during pregnancy, right? You're going to be there a lot, but the idea that we're ever going to have enough capacity on the ground in our communities is not realistic, and it's not necessary. So, we have to kind of operate within the multiple types of care and modalities exist. Who needs what when, and where's the best place? Where's the best setting for that care?
Well, and now that we're living in a world where the Medicaid population by and large has access to smartphones through which they can have virtual visits. You probably can do things now you couldn't do in 2017.
Completely. And we saw it change before our eyes. Like with 2017, 2018, we came across a lot of folks who did not have devices, and that changed. But you are absolutely right that we have a long way to go. It's improving so fast, but we still have a long way to go with there being reliable, sustainable access, internet access, people having Wi-Fi where they live, people having enough data on their phones. It is so much cheaper than not getting people the care that they need and having them need to use the emergency room or the hospital. So, we were on
If we could get reimbursement rates that reflect the value of mental health services, I'm sure we'd have more trained providers. We would have more access. But pending that, I mean, it's possible. Well, I love your thoughts. It's possible that as we move into value-based payment, if we have the right metrics and measurements and quality standards for mental health care, maybe we don't have to talk about fee-for-service inequity anymore.
The one thing I worry about is that we don't want to create a world in which people only get care when they meet a certain threshold or standard. We do want to continue to say, we don't even have to know if there's something going on. you can have an assessment or you can see a professional and be evaluated, which tends to lend itself. I mean, unless there are ways that the fully risk universe could make this work. But that's one of the reasons we like to have both fee for service, and when we have alternative payment models, they can coexist. Because if there's an alternative payment model we have in place that is only applicable for somebody who has recently been hospitalized, yes, we want to give them care in an episodic model that we think is really effective. But if there's somebody who recently had a child and is experiencing some symptoms and they're not sure what's going on, we want there to be absolutely no pressure for you to meet some specific criterion to talk to us. And so that's just one of the things I think about as we look at
Yeah, I
the
mean,
innovative
reducing
models.
friction. Yeah, I mean, reducing friction for sure is a I've heard it a lot as a goal. It's super tough. It's super tough.
It's super tough. And in some ways, I think that that's what we do at Brave, because there are many organizations locally that deliver amazing care. There are other national organizations that deliver amazing care. There are also increasingly startups that deliver services around community health work and around locating members health plan members that are not in close touch with the health plan or with other providers. Then there's this big group of people who the health plan's talking to, the PCP is talking to, maybe they've been hospitalized and the discharge planner is talking to. We know who they are, we know where they are, but if we say, here's an address of somewhere an hour from your home by bus and just get there at 8 a.m. and wait online, nothing's going to happen. And this is how you get to the kind of, I mean, would you do that? Like, I understand why someone would say, I don't think I can make that work. And so that's how we get to the kind of stats we see where there are hospitals, you know, at least in Florida that I'm aware of, where if 100 people are hospitalized for a psychiatric illness, maybe 15 have an appointment within 7 days after discharge. And it's not because they weren't given instructions or an option. It's because it's really high friction to actually engage in that option. So that's kind of how I think about what Brave does. Is it's our job to take the people who we know need services and take away all the barriers to them getting those services.
Right. Right, and the whole health system should be aligned, right? I mean, the whole health system should in theory be aligned with that, right? If we're really focused on outcomes. So I'm interested, sort of what is the hardest part, or um, what is the most challenging part of making sure that you're able to move the needle for this population in particular?
Hmm. I do think your point about a broader embrace of alternative payment models is important. One of the hard parts is if you go into a state where the Medicaid fee schedule doesn't work and the health plan's not willing to negotiate, you're stuck. There's nothing you can do. We have states where we've gotten a contract from a health plan that says, okay, so your 30-minute medication check visit for someone, who may have schizophrenia, you're going to be reimbursed $25, $30. Like, you can't make that work. It's a dramatic money loser. And that's not the norm, but that's an extreme example. But I do think the time it takes, because now we have enhanced fee for service and alternative payment models, but it takes time. You have to get a bunch of data. And so tens of thousands of patients in,
Sounds
you
like
have it.
yeah.
Yeah.
Sounds like a good moat for you, at least, having sort of like
It is, but it's
created that.
also, it's kind of depressing because you don't want to feel like I'm so grateful for the data that we have and the traction that we've made, and I'm really proud of what the team has accomplished. But I also, and I think we have a defensible business for a number of reasons that is wonderful. That's good, and those elements have been built intentionally. But you don't want to feel like somebody else could want to do work that helps this be a healthier country, and it's not possible.
Yeah. Well, I mean, this is what a mission-driven founder grapples with,
Yeah.
right?
Yeah,
Um,
yeah. And I mean, I think that it's also, then it comes back to the conversation about funding, because tip historically, a lot of the work that happens in community mental health is grant funded, which is great. But there are certain things that grant funding is great for, and other things that it's not designed for. I don't know what grant would have given us the $10 million it took to put in like world leading technology. So it's not like, oh, just nobody ever thought of this before. It's we have, been really fortunate to have venture investing that's allowed us to install some of the infrastructure that is existent in other settings, but not for Medicaid beneficiaries typically.
So, okay, so I have one question, two parts. Um, how will you know when Brave has been successful? And how will you know when you've been successful?
Hmm. Um, Brave's work will never be done, right? Like we grew by 20 times in 2020. We're on track to triple this year, and that was obviously all hell broke loose in 2020. So it was an intense year for every single person in healthcare, and we were really fortunate that we didn't have to physically endanger ourselves, and really lucky that we were already a virtual provider, so we didn't have to completely manipulate our operations. But we could grow another 20 times, and we'd be scratching the surface of the problem. And that's the thing. And so our work will be done when anybody with any type of insurance in the United States feels like if they need help, they know how to get it. And there are other
That's a big one.
indicators.
We call that a BHAG.
Yeah,
Big, hairy, audacious goal.
but it will be cheaper to the country if that's the case. Truly, it truly will. I mean, we have a patient who was hospitalized 37 times in like the 2 months before she came to us. And she was talking to her case manager, and being given a plan, being given follow up after hospitalization plans that weren't effective for her. And that case manager said, we're going to try something different. And she came to Brave, and we got her on a plan that was working, and she had a really good stability for a long time. And I think we don't want people to feel like the system has given up on them. And I can see why someone would feel that way. I mean, I've had my own, it's like I have had insurance through my employer for my entire career, and I have had many times when I've been frustrated navigating the system. And it's not because, I got to say, the people who work at health plans, like the case managers we work with, are amazing. They work so hard for their members, but it is a very tricky system. And there's some weird incentives. And so, the other thing I think about is we will have a sense of accomplishment when no OBGYN, no pediatrician, no PCP feels scared to ask a patient about their behavioral health symptoms, because if they know, they have nowhere to send them. That is like a tragic thing. When we've created a system where actually you're like, I would love to know what's going on with you because I want to offer you options. And I don't feel any concern that then if I suggest things to you, they'll all be filled, or there'll be nowhere for me to put, for me to send you. And then just personally, I really want to work with the hospitals, like all of the safety net hospitals in the country, the ones with the highest admissions, someday I said the other day, I want to work with Bellevue, and someone said, like, that may take you a while. And I was like, well, we've been at this 5 years, so
Yeah,
I got time. Like,
yeah.
how long?
I love it.
Because I think those are some of the places where we can have the biggest impact on people who have been, this is kind of like what Dr. Insel talks about in his book, and then some of the work that he's, been publicity that he's been doing lately, that, you get people who are just in a cycle of not getting the kind of care that they need, and so just a lot of human suffering. And it's kind of can be clustered around some of these types of safety net organizations that are doing the absolute best they can. But I think we can help.
Well, I am sure that you will. I'm sort of picturing how you describe this, and I'm a big fan of sort of visualizing success. I think you've got a good picture of it. I will ask you, as the sort of closing piece here, what I ask most folks that come on the podcast. And that is, what's one piece of advice that you would give to the innovators out there who are building alongside you to help them supercharge their success in the space?
Get an advisory board sooner than you think you need it. I was an outsider. Like, I didn't come from healthcare. And even if I had, unless you, I mean, maybe there, I know there are founders who have decades of experience in the space and have had 5 other startups, and maybe that's different. It's different for them, but I couldn't imagine what this would have been like if we hadn't had our advisory board of people who'd been health plan executives who explained to me what acronyms were so I didn't have to look silly in a meeting, right? Who
That's right. Healthcare
looked up pricing
is global.
proposals, and told me, I mean, I have had just the most amazing guidance of don't undersell yourself. Don't settle for that. Push back. Hold your, just like hold the line on what you think is fair. I've countless introductions made, meetings brokered. I mean, these are people who have spent their careers in the space and have been and are still so generous to invest their time on someone who's new to the space. And that is a debt I will hope to be able to repay someday, but absolutely change the course of Brave.
Okay, so usually I close here, but I have to push on this a little bit because I get this question all of the time about timing for advisory boards, about how to incentivize them, all of that. But I'll just ask you one question, and then I think I'm going to write something about this eventually.
Please, that'll be great.
Where do you start? How do you get your first advisor? What does that look like?
Yeah, so I started the company, and employee 1 was someone who was an incumbent in the space, like someone who had worked in the space for a long time. And I found him through a completely amazing and serendipitous series of events. But he and I started working together. He was consulting for Brave. He still works for Brave. And he knew people. We were like, okay, who can help us? Who can help us? And we did equity grants, option grants. But once you get one person who knows some people and you can paint the picture and be passionate about your mission, and someone says, yeah, oh, and I also scoped it really small. I said, I want to talk to you 1 hour a month.
Oh, that's a good piece of advice, right? Like,
you do not have to do any meetings with other people. You don't have to travel. You don't have to commit to anything, but can you spare 1 hour per month on your calendar? And people would say yes to that. And then I was kind of like, well, how bad? I mean, 1 hour per month, she seems like she's like pretty intense about this. Like, okay, sure, I'll give it a try. And if we get to a point that it's not working for you, you can always bow out, but try it, And then once you get one person who will give you 1 hour a month, they will be like, here's the other person I think you should talk to. Here's the other person.
Yes. Okay. So this is gold. It seems simple to you, but I will tell you, this is something that's on the mind of so many founders. So I really, really appreciate your generosity of spirit. I am so glad that you are in the world and doing this work.
Same to you.
Thank you for everyone who is listening. Please like or subscribe or follow whatever it is that you do in your favorite streaming apps. I think we're everywhere. And I'm so grateful for your listen and your support. Have a great day.
Thank you. Bye-bye.